But our topic tonight is POTS, or Postural Orthostatic Tachycardia Syndrome, also known as POTS. So we want to establish tonight that there's hope beyond just salt, water, and medication. 3 very important tools that can help with POTS. But one thing that we find that's really common for the patients that we see that are dealing with POTS, one of the comments that we get from them is that they want more, right? Because oftentimes those 3 tools are the only things that they realize are at their disposal. And they're often surprised that they can come see us and there's so much we can do to help. So let's get this presentation going. Assuming I can get my remote to work, I apologize. Hold on one sec. All right, I think we're progressing through the slides now. So a little bit about myself. I'm Dr. Frank Patterson. I'm one of the clinicians here at Georgia Chiropractic Neurology Center. As all our doctors, I'm a licensed chiropractor. I'm board certified in chiropractic neurology. I have a fellowship of mild traumatic brain injury. And I joined Georgia Chiropractic Neurology Center in February 2023. Right? I interned here back in 2014, but it's awesome to be an employee here now as well and work with such an excellent team. We're very fortunate to have 7 doctors here on staff. We're going to get into this a little bit later, but we like to collaborate with patients, and it really benefits them. And it's just awesome to work in a collaborative environment. Speaking of that, I couldn't have gotten here on my own. There's some people I'd like to thank. I'd like to thank our clinic director, Dr. Mark Ellis, for being one of my mentors over the year. I'd like to thank Professor Carrick, Professor Ted Carrick, for being one of my mentors over the years. Some of the first POTS cases I got to see were in his clinic at Georgia Chiropractic Neurology Center when I was an intern. And then with the 2 docs that I worked with shortly after that, I want to thank Dr. Jim Duffy and Dr. Nathan Kaiser as well. Dr. Kaiser does some great work with people with POTS as well. And I learned a lot about the condition and how to treat it from all my mentors. So what is Georgia Chiropractic Neurology Center? We are chiropractors specializing in multidisciplinary neurorehabilitation. So what does that mean? We pool different disciplines, right? Information from different disciplines, thought processes, treatment modalities. There's aspects of vestibular rehabilitation we do here. There's aspects of visual rehabilitation that we do here. Naturally, we're chiropractors, so that's going to be an element of our care as well. But we're pulling from multiple different disciplines. But we harness the brain's ability to change and adapt, also known as neuroplasticity, to restore function, ease symptoms, and get you back to life. So our topics for this talk: what is POTS? How is POTS typically diagnosed? How is POTS typically treated? And yes, there is treatment in addition to water, salt, and medication, as I said earlier. Right? So we're going to talk about how here at Georgia Chiropractic Neurology Center, there's other things that can be done to progress your symptoms with POTS. And we're going to talk about some patient stories of some of the successes that we've had with patients. And then we'll have time for questions at the end. If you guys have questions, you can put them in the chat. I'll try and address some a little bit as we go, but we will definitely get them addressed by the end. So there's some takeaways I want you to have by the time we get to the end of this talk. So we need to understand that POTS is complex, not only from dealing with it, right, at a patient level, but it's very complex to diagnose it, and it's very complex to treat it. I wish we had some kind of treatment algorithm and I could just give it to you tonight and be like, hey, you do these things and you're going to get better. But each individual needs individualized care, and that's what we specialize in here. We also need, like I said, to understand that diagnosing POTS is complex, right? And that treating POTS is complex, like I said, but it's possible, right? It's possible. So before we dive in too much about what POTS is, Postural Orthostatic Tachycardia Syndrome, we need to first understand that it's a type of dysautonomia. So we need to understand a little bit about what dysautonomia is. It essentially means that we're having poor functionality of our autonomic nervous system. And we're going to talk a little bit about what our autonomic nervous system is and how that plays a role in our health every day. But you can see under this umbrella up here, and let's see if my pointer works. This is a good test. I think maybe you can see my cursor.
Yep.
Can you see it on the broadcast? Maybe not. All right.
You can see it.
Yeah, you can. Great. Awesome. So dysautonomia is an umbrella term, hence why we have the umbrella up there. I want to thank reflectionsofabear.com because they're the ones that created this infographic that when you look up umbrella term POTS, this is all over the place. So thank you so much for creating this for the community. But you can see that POTS is under the umbrella of dysautonomia. There's a bunch of different diagnoses: multiple system atrophy, familial dysautonomia, autoimmune autonomic ganglionopathy. There's a bunch of different things that fall under the umbrella of dysautonomia. Also things like fibromyalgia, which was thought to be, more of just a straight-laced pain-based syndrome. And there is pain involved, don't get me wrong, but it has to do with your autonomic nervous system being behind what's going on with your pain. So not everything is necessarily represented up here. I think we're going to do a talk at some point regarding dysautonomia. It's a pretty broad topic, but I feel like we need to talk about it as a whole. But we've had such a demand from people wanting to know more about POTS, and that's why we're starting with POTS this evening. So what is dysautonomia? As I said, it's poor autonomic nervous system function, right? So POTS is a disorder of the autonomic nervous system function, right? So what is the autonomic nervous system and why do we care about it so much? So the autonomic nervous system is essentially automatic functions our nervous system controls to maintain homeostasis in a dynamic world. So what exactly does that mean? We live in a world with moments of happiness, and we live in a world that can sometimes be fraught with danger, right? We need to adapt to those different environments. If we're in a safe environment, then we need to be in a more restful state. If we're in a dangerous environment, then we need to be hypervigilant in the environment we're in, but we need to be able to adapt to both environments, right? We need to be able to go from one to the other. And oftentimes people with dysautonomia are caught in a state that's ramped up, right, as far as our autonomic nervous system function, and just ramped up in general. They feel ramped up, right? And they may be in what they know logically to be a very safe place, right? But their system is just really ramped up. So let's talk a little bit about the autonomic nervous system. There's different aspects to our physiology and parts of our body that are involved with the autonomic nervous system. So it's kind of falls into two different camps. I brought up this this chart because I feel like it breaks things down a little bit. I apologize, there's a lot of verbiage in here. But essentially you can see one column is the sympathetic nervous system, and that's kind of the fight or flight side of things, as it's called sometimes. That's that more ramped up state. And then there's also the parasympathetic nervous system. That's more on the calming side of things, right? That's also known as rest and digest, or also known as feed and breed. So you can see with eyes, pupils are going to dilate if you're in a sympathetic state. Excuse me. Your ciliary muscles are going to relax, which are some muscles in your eye that change the shape of the lens. You're also going to have your pupils constrict if you're in a parasympathetic state, if you're in a more restful state. We want pupillary dilation. We want to take in more visual information if we're in that ramped up sympathetic state, if we're in a place that's dangerous, right? Our salivary glands are going to be stimulated if we're in a more restful state, because we're in that rest and digest state, right? Whereas we're going to inhibit that salivation if we're in that sympathetic state, where we're more ramped up. I'm not necessarily going to go down the list in its entirety. Plus, you guys can see it there. Hopefully, you can read it. Hopefully, it's big enough. But we need to know that the heart rate increases when the sympathetic, ramped up part of the nervous system is kicking in. And we need to know that the heart rate decreases when we're in that parasympathetic, more restful state, right? Because heart rate is going to be a factor in POTS, if you did not already know that. Digestive system, we're going to have essentially decreases in the secretions of digestive enzymes if you're in that sympathetic state. If you're in that more restful parasympathetic state, it's rest and digest. As I said, we're going to increase secretion. So you can see if things get out of whack, different symptoms could pop up, right? We may have dry eyes. We may have eyes that tear up. We may have digestive issues for a variety of reasons. We may have increased heart rate. We may have sudden drops in heart rate. If this state of homeostasis cannot be achieved because the autonomic nervous system is ramped up, then we've got a problem. All right. So let's talk a little bit about what should happen when you stand up. So ideally, you stand up. And we're talking about positional changes because postural orthostatic tachycardia syndrome means that you have a postural change. Typically, you're talking about going from lying down to standing up, okay? And then you have a rapid increase in heart rate. And we're going to get to how that happens and a little bit about why that happens. But let's talk about what should normally happen when you stand up, when you aren't suffering from issues with POTS, okay? So you should stand up. We've got about 500 to 800 milliliters of blood that moves down to your abdomen and your legs because we stand up against gravity, okay? And then your senses accurately pick up this positional change, okay? And your brain appropriately processes these sensations as you stand up. So, right, we changed position. Our senses take that in. Visually, I can see I'm standing. My joints and muscles tell me I'm standing. My inner ear processing that tells me where I'm in gravity. If I'm rotating or tilting, right, called your vestibular system, that lets me know I'm changing position. My brain should be able to process that information, okay, that I'm standing up, and then my autonomic nervous system should be accurately activated, meaning that my heart rate should increase a little bit, okay? There should be a temporary increase in my heart rate, but it shouldn't be above 30 beats per minute. That's not necessarily the end-all be-all number, but as we're going to get to in a little bit, that is the number that we need to be officially diagnosed with POTS. But if we have too high of a heart rate, right, then we're going to have issues where we're going to get symptoms. We're not going to feel good and we're not going to function well. But anyway, that heart rate should temporarily increase at a fairly low level, and our blood vessels should contract to make sure that we have good blood flow to our brain. Okay, because if we lose that blood flow to the brain, that's where dizziness can come in. Right? Disorientation, a lot of the symptoms that people are going to experience when they change positions with POTS. Okay? So we go to standing. Our senses pick up that we're standing. Our brain processes that. It makes the appropriate adjustments to our autonomic nervous system for those changes in position, increases heart rate a little bit, constricts blood vessels in my legs and my abdomen, and then I get good blood flow to my brain, okay? And you can interact in the world standing without symptoms. So what is POTS, Postural Orthostatic Tachycardia syndrome? It's not standing up and having things happen appropriately. You can kind of see this picture here, and I apologize, my points here are gonna pop up out of order. Something I'm gonna need to fix for next time. But anyway, you can see that people are changing position here. It'd be a little bit more accurate if you saw seated then standing. But anyway, imagine someone's seated at first and they have appropriate blood levels in different areas because we don't have to fight against gravity as much. And then they stand up. That 500 to 800 milliliters of blood is not constricted in the vessels so that we can get good circulation to the brain, right? And then we get an excessive heart rate increase when we stand up, because if we're not constricting the blood vessels, one way or another, we got to get blood to the brain, right? So we can either shrink our dynamic plumbing, right, the size of the pumps to increase some blood pressure a little bit and make sure that volume goes up to the brain as far as blood, or we can increase the rate that the pump is pumping, and that's your heart, right? So if you have POTS, technically, a basic definition is you stand up, your heart rate increases, you don't really have a drop in blood pressure, because that could be something else. Doesn't mean if you get a huge spike in your heart rate and your blood pressure drops, that you should feel fine and it's not a big deal. That's an issue, but that's technically something else, okay? And when this happens, when you stand up, get the increase in heart rate, and you don't really get a drop in blood pressure, you're going to get many different symptoms, and we're going to go over some of those symptoms. So it should also be known that POTS is sort of a new diagnosis. It's been around since 1993. That's when it was first named. But according to the research articles I dove into, you could find information that dates all the way back to the 1800s as far as people describing some symptoms that sounded like POTS. I want to touch a little bit too about the research articles that I went through preparing for this talk. I wanted to get some updated information, so I looked at some more contemporary ones. There was a study that was done by the NIH. Well, it was not necessarily a study. It was basically a conference and a panel of many experts were brought in from the healthcare community to really dive into POTS because it's such a complex diagnosis, and there's a lot of aspects to it. And quite frankly, it's often misdiagnosed, and we're going to get into that as well. But anyway, there was this NIH meeting that happened in 2019, and then there were 2 research papers that summarized what was discussed during the meeting. That was one of the major papers that I looked at. There was a good review article from a little bit older from 2012 that I was looking at, and then there was also a consensus that was coming from Canada that was somewhat similar to the 2019 NIH meeting that happened. And that gave some really good information as well, and it gave some updates as far as how we should talk about POTS. But I just want to put that into context because I'll be referencing some information from these papers as we go. So who does POTS typically affect? It's oftentimes women 15 to 25 years old. I've seen varying statistics on that. Sometimes it's younger. Sometimes some of the statistics I find, we're talking about into their 40s. It could really happen at any age depending upon what precipitates the event. And we'll talk about some of the things that can bring on POTS in a little bit. But oftentimes it's women. That's like the one definitive thing. And we've seen men with POTS as well. But for one reason or another that's not fully understood, it really tends to affect women. So that should be known. So let's talk about standard criteria to get a POTS diagnosis. I gave you kind of the basic criteria. Stand up, big elevation in heart rate, right? We don't have a big change in your blood pressure as far as a drop, okay? And then you get symptoms. So that's a basic definition. But these are the criteria that I could gather from these multiple sources that I looked at. At one point, people were talking about needing a 20 beat per minute change in heart rate or increase in heart rate to be able to be diagnosed with POTS. But the more contemporary articles that I found are talking about 30 beats per minute at least. And it depends on your age. So that's for adults from 19 years old or older. And that's going from laying to upright. All right. We're going to see an increase of 30 beats per minute or more. Blood pressure cannot have a sustained decrease upon standing, right? Because that'd be something else. Doesn't mean it's not a problem, but we're talking about something else, okay? And with that, what do we consider a sustained decrease upon standing? What do we consider a significant number? The numbers that they came up with is 20 millimeters of mercury systolic. So that's the top number in your blood pressure, or 10 for the bottom number on your blood pressure, because it's usually described as this over this. 120 over 80 or 120 over 70. So what about adolescents and children? If you're less than 19 years old, you must have a sustained heart rate increase of greater than 40 beats per minute. So there can be a little bit of challenges with this. And one of the things that the Canadian article touched upon is we need to also look at, like, what is our baseline, right, for these changes? Because 30 points from what to what? Because that matters too. I'd argue you're probably going to have more significant symptoms if your resting heart rate is 100 lying down, and then you go to standing and it goes up to 130. You're going to feel that more, okay, as opposed to if you're 60 lying down and you go to 90. Not guaranteed, okay, but you're already starting out with a really high heart rate. And then there's some people that have pretty low resting heart rates, in particular typically athletes, where if they go and they stand up, the Canadian article is essentially arguing that, you know, maybe they don't need as significant of a change as far as 30 beats per minute, right? So I bring all these things up not to confuse people, not to confuse you. But like I said, one of the points that I want you to take away is that POTS is complex. Because I'm going to talk a lot about this stuff because there's so many aspects to it. And as we're going to get to, I'm going to show you some statistics, but it's often misdiagnosed. And that's not right. So we as clinicians really need to understand this information better so that we can accurately diagnose these people, because people with POTS are often misdiagnosed for years before they realize what they have, so that we can get down to business and get them functioning and feeling better. So frequent symptoms of orthostatic intolerance. I'm not saying this is the master list. Okay, this is just a generalized list. We're going to go into a more detailed list, and I'm not saying that's the master list either. All right, but a list of some of the things that people might feel as far as with orthostatic intolerance, or when you stand up and you can't regulate good heart rate or blood pressure. We're talking about lightheadedness, palpitations of your heart, tremulousness. So that's like a kind of almost like a tremor. Generalized weakness and blurred vision. All right, and you have to have these symptoms for 3 months. So if you're early on in the process, they're probably not going to technically diagnose you as POTS. But the gray area is some people would. It doesn't mean they're wrong. But it helps to know if this is a chronic condition, or maybe if you're just dealing with something short term. And POTS is considered to be a more chronic condition. All right. Now here's where, you know, these numbers are really at play, like I talked about. In particular, the aspect that blood pressure can't drop a significant amount when you stand up, right, and have POTS, because you could have one of these other things, right? And you may be experiencing these other issues, and they could lead to autonomic nervous system dysfunction. Because remember the umbrella? There was a bunch of stuff on the umbrella, and I said that's not enough because there's so many other things out there. So we need to make sure that you don't have these other conditions going on, because this could be more at the root of what's going on. Talking about anorexia nervosa, primary anxiety disorders, hyperventilation, anemia, fever, pain, infection, dehydration, hyperthyroidism, pheochromocytoma, which is a type of adrenal tumor, cardioactive drugs, right, which affect your heart, or severe deconditioning caused by prolonged rest. And I think it should say bed rest, but not just taking a nap. But there's some people that have been hospitalized for something else, and they're just really deconditioned, right? And their autonomic nervous system just is kind of out of shape, right? And it's deconditioned, and it's just not working appropriately. So we need to take these other factors into account. We can help with some of these other factors, right? We can help with a lot of these other factors to a certain extent. But we need to know what we're dealing with, okay? So having an appropriate diagnosis is important. So POTS is more than dizziness and fatigue. We need to understand that. I talked about that list of symptoms that I just read, and it's great. You know, have that little short, concise list. But at the end of the day, there's a lot of things going on, right? I talked about the lightheadedness, palpitations, you know, the tremulousness, the atypical, I don't think I mentioned atypical chest discomfort. But here's some of the other symptoms. And then there's symptoms that the literature was talking about not based on position. I would argue that's a bit of a gray area, right? You can see where maybe you go and you stand up and then your sleep is not going to be disturbed in the moment. But if your autonomic nervous system's out of whack because you're constantly changing positions during the day, it's probably going to affect your sleep at night. All this stuff is intermingled, right? You could definitely see where you're going to be exercise intolerant if your autonomic nervous system isn't regulating things very well when you stand up. How are you going to stand up and exercise if things are out of whack? But anyway, you could also have perceived cognitive impairment or brain fog. Peripheral acrocyanosis, otherwise known as POTS feet. It's like severe discoloration in your feet and sometimes your ankles. Frequent nausea, mild diarrhea, constipation, bloating, and unspecified abdominal pain, or irritable bowel syndrome. I would argue that that can get severe as well. But just to get into the complexities a little bit more, there's some other symptoms we're going to talk about. But also, before we get to those, let's talk about some exacerbating factors, some things that can ramp up your symptoms here. Heat exposure, physical exertion, heavy meals, just eating food, right, can ramp up your POTS, which can make eating difficult, where you can see if you're not eating well, we've got a whole cascade of other issues that can happen. And laying for long periods, right? Even though you feel better on the ground, right, or laying on a bed because you're not going to get dizzy, you're just going to get further deconditioned. And that's one of the major factors of POTS, is that we just continue to get deconditioned because there's only so many things we can do. So we kind of rest because that's all we feel like we can do, but we just get further deconditioned, and it's a slippery slope. And then, yeah, menstruation can be a factor as well, right, with those hormonal shifts, because it just, it changes physiology, and we're a dynamic system, and that's just another aspect of the dynamic system. So the Canadians were proposing that there's also this thing called POTS Plus that should be a thing, basically. Meaning that you have not all, but you have the same symptoms as POTS, and you got one or more of these other issues, which is gastric emptying problems, intractable vomiting. Meaning you can't really do anything about it. It just happens, right? There's not much you can do to calm it down. Severe constipation, right? We went from mild constipation to severe constipation. They're saying this is POTS plus. A neurogenic bladder, severe chronic pain, intractable headaches, right? Meaning headaches that you can't really calm down, and significant flushing anaphylaxis symptoms. Severe food intolerances, right? We're going to talk about autoimmunity and food intolerances in a little bit. So then there's these other syndromes that you can have in addition to POTS, right? And this could feed into your POTS, and your POTS could feed into this, and it just gets more complex, okay? So there's hypermobile Ehlers-Danlos syndrome, right, or ED, people will talk about. You see a lot of patients where they either have ED or it's kind of suspected, right? If you wanted to find out more likely that you have ED, you could do genetic testing. There's also a hypermobile spectrum disorder. That kind of goes also with connective tissue. Mast cell activation disorder. And this one could be a nasty one. And we've seen this with mast cell activation issues as well with COVID. And COVID and POTS kind of go together, and we're going to talk about that in a little bit. Okay, chronic fatigue syndrome, or ME. Remember I talked about that was a type of dysautonomia? You're allowed to have more than one dysautonomia, unfortunately. Celiac disease, like I said, autoimmune disorder, chronic migraines, cerebral spinal fluid leak, mitochondrial mutation disorders. So the challenge is there's all these things on the table, and a lot of these things have similar symptoms to POTS. And this is where people get stuck sometimes. And they'll have multiple labels. And it's a horrible place to be in. And you've seen specialist after specialist after specialist. And people are throwing different diagnoses at you. And you don't know. Because if you've got a label on something, then you know where you're headed. And you've got a game plan that you can start to build. But if you're hearing all these different conditions thrown out there, and it's not to say that you can't have more than one. It's just a really tough place to be in. And that needs to be acknowledged. Because we hear from patients all the time that they get these quick appointments and these things aren't acknowledged, and sometimes these names of disorders are thrown out there. We also need to understand too that it's very difficult for the doctors, right, to diagnose, because there's so many things on the table, and I talked about so many different aspects that you need for a POTS diagnosis, but there's so many things that could look like POTS, right? But it's not quite POTS. And it's important to have an accurate diagnosis, but it's the ultimate is to understand the physiology that the person is dealing with that's out of whack and understand how to get that back in order. I would argue that's kind of number one at the list. But what can be helpful in that process is to know the diagnosis that you have so you can better understand the physiology. But we're going to talk about how the physiology, the pathophysiology, the physiology that's gone wrong with POTS is very complex as well. And I'll get to the hopeful part. I know this is pretty heavy stuff, but it's worth talking about because it's important and it's often missed. But it's heavy, but we're going to get to the hope, I promise. Multiple sclerosis as well is in there. So what causes POTS? So I hope people can read this. It may be a little bit difficult, but I'll read portions of it for us. So there's different thought processes as far as what's going on. I mentioned physical deconditioning. You know, maybe you caught an illness or had an injury and you've been on bed rest, you know, for weeks or maybe months, and your system gets deconditioned, right? But you can regulate that blood pressure when you stand up, but you can't regulate that heart rate. So maybe that's a factor, right? It could also go with somebody that has a chronic fatigue issue, which chronic fatigue is another type of dysautonomia, right? You know, or people dealing with pain. So one of the things that they can do to test for that is they can look at your VO2 max, right? It needs to be less than 85% on exercise testing. So it's a test that they can run. They can also look at your ventricular mass and see if that's a factor as well. So that's with physical deconditioning. There's also volume dysregulation, and I realize I'm going backwards on the chart, but that's just how I started. So volume dysregulation. We're talking about essentially your physiology being off, or your metabolic system as far as your renin and angiotensin aldosterone system. So there's these different hormones that are going to regulate your blood volume, right, or the volume of the fluids in your body. And what can happen is you have abnormally low volumes of fluid. So that could be a factor as well. You could also have basically what's called hyperadrenergic POTS, okay, where we're dumping a lot of adrenaline, which is another hormone, okay, into the system, and that's just ramping things up, and it's ramping up your heart rate. So some examples of what could ramp up your norepinephrine dumping in your body is anxiety. That tumor I talked about, pheochromocytoma, that's also the mast cell activation that I talked about, right? But has to deal with your immune system. And then, like I said, autoimmunity could be a factor as well. Then there's impaired sympathetically mediated vasoconstriction in the lower limb. So what does that mean? It's also known as neuropathic POTS. So essentially the wiring that is linked up to your blood vessels in your extremities, in particular in your legs, the wiring's off, right? Something chewed up the wiring. It's not working appropriately. That could happen with autoimmune issues, right? Or post-viral. And that's where COVID comes in the picture. A lot more people, fortunately and unfortunately, know about POTS now because of COVID. And we've seen a big rise in the number of POTS cases we've been attending to in the clinic since COVID started, because we've been dealing with POTS for well over a decade. But we're seeing more and more cases, and a lot of it's related to COVID, and we'll talk about that in a little bit. So essentially, you know, virus or autoimmune issues can mess up the wiring that's going to affect the ability to constrict and dilate those blood vessels, you know, that capability that we need. And like I said, what causes POTS? I just touched on it, COVID. COVID's a factor, right? Whether it's autoantibodies, what's known as a direct reaction to the infection, right? That can affect some of the pathways going through cells, okay? And then there's the fact that the COVID virus, could affect this wiring with the blood vessels, called neuroinvasion. So it's pretty similar whether you got POTS from COVID, and they knew that POTS could come from viruses long before COVID. Like that was in the literature before COVID came around. And then when COVID was happening, like in the clinic, we saw increases in POTS, and we're like, this seems to be related to COVID. We had our thoughts, but at this point, like the literature is really backing it up. There's a bunch of articles discussing how long COVID or post-COVID syndrome, one of the aspects of it very well could be POTS. At least one of the aspects of it could be POTS. And we've seen a lot more POTS, like I said, since COVID has started. But interestingly enough, in this infographic from an article about POTS and COVID is, as far as possible treatments, it's talking about medication, salt, and water. But as we're going to find out, there's more that can be done. So how is it typically diagnosed? This section will be a little bit shorter. I'm going to give you the quick and dirty, and this is typically the story that we get from our patients. And then I'm going to give you the more in-depth version that typically isn't done. So it's going to be examination by a cardiologist to rule out other potential issues with or effects on the cardiovascular function, right? Because you could have some other disorder other than POTS, right? And they're typically going to perform a tilt table test, right? Where they tilt you at various degrees, slowly elevating you upward, monitoring your heart rate, blood pressure, an EKG, your O2 saturation, and some other factors, and looking for significant changes as you tilt up on the table and you're fighting against gravity more, right? Or an echocardiogram, right? They may do a Holter monitor where they're going to monitor your heart rate over a longer period of time as well. And then this is the more in-depth version. So yes, cardiac evaluation is in there, and ECG is in there, like I talked about. Holter monitoring is in there, right? And we want to exclude a primary cardiac cause of inappropriate sinus tachycardia, meaning that something that's more inherent to the heart. That could be an issue. It may not be POTS. It may be just something more inherent to the heart, because we know a little bit about the physiology of POTS, or the pathophysiology rather, but that's not set in stone either. That's just our understanding, and the literature talks about how our understanding is incomplete with POTS. Head-up tilt, which is sometimes a tilt table assessment is more gradual. Head-up tilt, you go up to 60 degrees and you're at that angle for 10 minutes, and then we just need to see that spike in heart rate rather at some point during those 10 minutes. And then there's cardiovagal and pseudomotor function tests. So that can see if we got that, autonomic neuropathy, meaning that the nerves have been affected. That's going to affect those blood vessels. There's lab work that can be done, such as plasma catecholamine, right? Looking at those aspects, whether you're lying down or standing up. 24-hour blood pressure and heart rate monitoring. Exercise with VO2 max, like I talked about, which is trying to look at physical deconditioning. And then it talks about measuring cortisol levels in the morning and in the afternoon or evening, right? So evaluate for chronic fatigue, checking your thyroid, right? Checking your salt levels in your urine. We might do an MRI of the head. We could look at gastrointestinal, intestinal or urologic evaluations, looking at your urinary system, right? And that's for POTS patients with suspected functional visceral dysmotility syndromes. So those genital, gastrointestinal or urological systems are not working well. And then there's behavioral medicine. And that's a slippery slope with the behavioral medicine, because sometimes people just get put in that box and they're labeled as having a psychological disorder when they have a neurological and cardiological disorder known as POTS, or maybe some other type of dysautonomia. But they just appear really anxious. And one of the things that I don't think I mentioned earlier, which needs to be mentioned, and it's not mentioned often enough, and I apologize, because that should have been at the front, is that POTS, as far as the definition, it's an invisible diagnosis, meaning that other people can't see it. A concussion is an invisible diagnosis. It's not a cast that you wear on your arm. Other people can be pretty judgmental of people that are living with POTS or other type of dysautonomia. It's a difficult thing because it's invisible, so we can't see it. And if we don't fully understand this, it's very difficult for us to sympathize with other people that are dealing with these sometimes debilitating issues, right? But it's an invisible diagnosis. But it doesn't mean that it's not there. Some things are psychological, some things aren't. That's why you need the right diagnosis. So how is POTS typically treated? I'm kind of beating this to death, but salt, water, and medication. Once again, powerful tools. What's the idea with salt and water? You want to increase that blood volume. So the way to retain that massive amount of water that you're drinking is you consume a lot of salt with it, and you're going to retain that water with those high salt levels. But it's a means to an end. You're going to pee out that water at some point, right? So you got to continually keep consuming massive amounts of water and salt, right? And then there's medications that can help as well. Medications are typically managed by a cardiologist. So let's talk about what else can be done. So it's interesting because the literature talks about how there's non-pharmacological, meaning non-medication related therapies, and then there's medication related therapies. And all the articles that I found advocate that the non-medical stuff should be done before medication should be brought in. But the vast majority of patients that we see, like, yes, salt intake and water intake is non-pharmacological, not drug related, right? But then they go to the medications. But you can see here that, and these aren't necessarily the things that people are coming to see us for. We're going to get to that. But these are other things that can be done, right, to help at least on the day-to-day basis. It's probably not going to get to the root cause, but it's going to help you function better on the day-to-day basis and hopefully prevent you from getting severely deconditioned. But we're looking at avoidance of precipitating factors. So what does that mean? Maybe you shouldn't do sudden head-up postural changes, maybe meaning you shouldn't pop up out of bed. You want to take that slowly. At times, you want to lie down or prolong recumbency. But you also, don't want to get deconditioned. So there's also high environmental temperatures. I talked about like heat and cold intolerance is an issue, but high heat, right? Hot days really tends to mess with people with POTS. So air conditioning can be your friend. Large meals, you want to avoid having large meals, so maybe you have smaller meals. There's alcohol to consider. There's vasodilator drugs. Maybe you want to better regulate those so you don't get too much dilation, right? Or there's drugs that can ramp up your sympathetic nervous system. You got to watch out for that as well. So there's increase in salt and water intake. There's sleeping with a relative head-up tilt at night, okay? And then there's also support garments. We do see a fair number of patients with support garments that can be helpful. Like I said, on the short term, right? There's other things that can be done to get a little bit more to the root of what's going on, but support garments can be beneficial, meaning that it constricts around your legs, right? And it helps make sure that you don't get as much pooling of blood in those lower extremities. Typically, there's a bigger recommendation for abdominal binding as opposed to the ones for your legs, although it could prove helpful. The generalized recommendation is that you figure out the amount of tension or tightness of those support garments that works for you. Start out lower and don't necessarily go to the most supportive or the most constricting. The downside of those is heat intolerance, right? Those can be hot. A big one is graded aerobic exercise. And some of the articles I looked at, they're talking about like 30 minutes of physical activity 4 times a week, but that can be very difficult. But you want to do physical activity in the ways that you can. And for some people, it's walking. For some people, they need to be more flat. So maybe something like a recumbent bike, which allows you to lie lower to the ground, right? As opposed to being more upright on a regular bicycle. You're in a more seated position when you're on a recumbent bike. So you may be able to tolerate that better. Or it also talks about a rowing machine as well, right? Because you're lower to the ground, you're not fighting against gravity as much. But one of the missing pieces that this literature talked about was graded exercise for people to not get deconditioned and to build up their tolerance to what they can handle. But it's a slippery slope because you may have chronic fatigue issues as well. And it's difficult to build your system back up, right? And it's difficult to know how much is enough and how much is too much. And we're going to talk about that a little bit later as far as, what progress looks like. Because progress is complex when you have dysautonomia or POTS. And then, behavioral medicine may be a factor, right? Behavioral medicine may be a factor, meaning that you've been dealing with a lot of crap. So you may benefit from doing some like cognitive behavioral therapy, or you may benefit from just having someone to talk to, right? As far as a counselor, because you've been dealing with a lot of stuff and there's a fair bit of trauma that can go with it too, even just trying to get the diagnosis. So it can be a part of the picture because there can be psychological aspects, but it doesn't mean you have an exclusively psychological disorder. And then I think, sorry, got a little turned around there. Here's some of the medications. Fludrocortisone for volume expansion, trying to increase the volume of the heart, but that may worsen headache. Midodrine for vasoconstriction, right? So we got smaller blood vessels because they have trouble constricting in the first place, possibly. But that may worsen GI symptoms or urinary retention. So it's tough. Like, there's side effects to these things. So you got to find the right mix of medications that could potentially work for you. And it's tough because it's going to shift your physiology and it may make you feel better. But it's not likely that you take this medication for a period of time and it's going to get to the root cause of what's going on. But it can certainly make you feel and function better in the meantime. It's definitely a possibility. So it can be in the mix as well. A lot of patients are on beta blockers in particular. We hear that a lot, is beta blockers is probably one of the more common ones, beta blockers. There's other medications that were not on this list, and medication, us being chiropractors, is not our specialty, right? So I don't want to talk too much about it. But there's a whole host of medications that are typically applied to this. But it's difficult. You got to find the right ones that work for you. And that can be a very challenging process. And most of the patients that we see, like, they just weren't responding well to medication. Or they responded somewhat, but not to the level that they need to get back to their life. So how is POTS typically treated? So we talked about the different avenues that you can go down. But we also need to know what this NIH article talked about as far as what's going on in the scientific community with this. So at this point, there are no FDA-approved medications for the treatment of POTS. I just gave you the list of medications that's typically treated. And I'm not saying you should get those, but just know that they're there, right? But the reality is those aren't FDA approved for the treatment of POTS. Take that as you will. A lot of things are used off-label. But just know that there's nothing that's FDA approved for POTS. And more importantly, evidence of the efficacy or how well these work for many of the medications, how well these medications work as far as being used to treat for POTS, it's not robust. Meaning that it's not great as far as research that backs up that these medications work, okay? There are currently very few dedicated specialty clinics for POTS and even fewer multidisciplinary programs, and that's problematic, right? Because there's arguably an increasing number of people being diagnosed with POTS. I can only speak to it anecdotally in our clinic, but we see a lot and we get a lot of phone calls. And the challenge is people get the diagnosis, and they get their salt, they get their water, they get their medication, and they want more. And no one really knows where to tell them to go to. And then they find us, and then we can help. So meaningful discussions of autonomic disorders, including POTS, are not included in most medical school curricula. Let me say that again. Meaningful discussion of autonomic disorders, including POTS, are not included in most medical school curricula, meaning it's not in the curriculum in the medical schools, or even in residency fellowship training in relevant specialties, right? So you're not getting it in more generalized medical school. Don't get me wrong, I'm not saying medical school is generalized. It's a beast, right? You learn a lot of important stuff. You get to be very knowledgeable, but there's nothing really in the curriculum about autonomic disorders, including POTS, right? So dysautonomia is not really covered. And then it's not really covered when you get to your specialty. What are some of these specialties? Okay, pediatrics, internal medicine, family medicine, cardiology. I would think cardiology should be really knowledgeable in this, because this is typically where you're going to get your diagnosis from. So you have to see a specialized cardiologist who specializes in POTS to get that diagnosis oftentimes. And that can be really tricky to even find one. Gastroenterology and neurology, right? So all these, pediatricians are not well-versed in internal medicine, family medicine, cardiology, gastroenterology, and neurology, right? That's a challenge. On average, POTS patients wait over 4 years for a POTS diagnosis from symptoms onset. This is from the NIH. With 75% of patients experiencing one or more misdiagnoses. 75% of people are going to get at least one misdiagnosis before they get their POTS diagnosis. Like I said, it's complex. I'm not saying that the doctors are totally to blame here, right, as far as misdiagnosing POTS, because it's complex. We just need to do a better job of getting the word out and getting better education on these autonomic nervous system disorders and what can be done about them and how to diagnose them. Patients see an average of 7 physicians for their symptoms prior to a POTS diagnosis. It's interesting because we often talk about that in the clinic. We talk to patients and we're like, well, who did you see? Tell me who you've seen before you got here, because that can help us figure out, what the logical next steps are for people that, haven't even been in the door yet. And we certainly want to know it when we're going over your history, so we know what's worked for you, what hasn't worked for you, because that can guide us down the path of how we can help you. And we often hear, whether it's POTS or post-concussion syndrome, even vertigo, right? Many of the disorders that we're working with. Very challenging issues. Most of the people have been to like 5, 6, 7, 8 other doctors before they find us. So even when a diagnosis of POTS is made, physicians are often unable or unwilling to coordinate care. I'm not saying this. The National Institute of Health said this in their article, or the authors of the paper, right, that published it from the consortium from the National Institute of Health. I'm not saying this. This is a quote. Even when a diagnosis of POTS is made, physicians are often unable or unwilling to coordinate care. The number of physicians familiar with the care of POTS is insufficient for existing patient volume, and there appears to be an increase in POTS cases as some individuals with COVID-19 are developing post-viral POTS. So that's a lot of heavy stuff. Sorry, my next slide is a little bit off. But yeah, it's a lot of heavy stuff. But it's really important that we understand that it's a complex disorder. It's a complex diagnosis. It's a complex treatment, right? And we need to look at the complexity and break it apart. And I believe, and what we found here, is that there seems to be a missing factor in the diagnosis. But we saw it in a previous slide. Let me go back. Let me find it. Cardiology, gastroenterology, and neurology. So we need to look at the neurological aspects of this. It's dysautonomia, meaning poor function of the autonomic nervous system. some of the patients that come in, they've been to see a neurologist, but there aren't a whole lot of options coming from the neurologist other than salt, water, medication. And if they're fortunate, they may have recommended, those restrictive or constricting garments, or, maybe even some graded exercise, but with not a lot of guidance as far as how to do that sometimes. But we need to look at the neurological aspects of this. So underneath this diagram is supposed to talk about hope. And I apologize that the diagram is overlaying that, but there is hope. We need to look to the neurology, okay? So what we're looking at here is everything in orange, and I'm trying to bring my cursor up here. But you can see it. Everything in orange is aspects of our neurology, right, of our nervous system. And then if it goes awry, we can have some of these issues labeled in blue. And here's the thing, is some of these issues labeled in blue will feed back into our neurology, such as like behavioral amplification, somatic hypervigilance, conditioning anxiety, right? Increased sympathetic output. That's going to affect your neurology as well, because the brain may be getting robbed of oxygen because it's not getting good fuel, right, from blood. And then it can lead to more downstream effects that are in brown, right, as far as what's going on with the physiology. So this came from one of the reviewed articles as well, right? What we're doing that's different, where the hope lies, is looking at the functionality of your brain and affecting these different systems and evaluating these different systems as far as the function. It talked about MRI, right, in the evaluation of POTS, but most POTS patients have a very nice looking MRI. The structure is intact. It's a functional issue, okay? So I'm talking about neurorehab to create what should happen when you stand up, okay? So sensory and movement-based exercises, like the ones that we perform, recalibrate your brain's processing of your environment so you know where you are in space relative to gravity. And we're going to talk about that a little bit more in depth. And I talked about it when I talked about brain injury a few months ago, right? We need to know where we are in the world, where the world is relative to us. What position are we in the world? That's what's going on in POTS, is we're having issues where we don't know what position we're in, right? There's those other pathophysiological aspects that I talked about. Those are definitely real, right? But our brain, because of those pathophysiological aspects, right, because of the things that we discussed, you don't know where you are in space as far as when you're changing those angles on the tilt table, or when you go to 60 degrees quickly, or when you just stand up, because your brain doesn't really know where you are in space. But if you know which areas of the brain have been affected, or the nervous system, then you can use sensory and movement-based exercises to recalibrate the processing of your environment done by the brain so that you know where you are in space relative to gravity. So you can stand up. You can constrict those blood vessels in your limbs and your abdomen, right? Your autonomic nervous system is appropriately activated. So you get a temporary increase in heart rate, and blood vessels constrict. You get good blood flow to your brain, and you interact in the world standing up without symptoms. I would argue this is where a lot of hope lies. But you got to be able to figure out what these exercises are. And if it was one set, I'd give them to you now. But that's the challenging thing, because once again, it's a complex diagnosis. So everybody needs different sensory movement-based exercises, even if the same area of the brain or the nervous system is involved. So how do we approach your care differently? Our in-depth knowledge of how information travels through the brain allows us to figure out your brain function challenges and the root cause of your issues. So we pool the collective knowledge, like I talked about earlier, from different avenues. We look at contemporary research and therapy applications from several professions. So we're looking at, like I said, vestibular rehab, visual and eye exercises. We're looking at, chiropractic adjustments. At times, we're going to look at, maybe some lab work or some dietary things. There's multiple things that we can look at. Our main focus is neurorehab, though, right? But our neurorehab pulls from different avenues. Like I said, there's some aspects of physical therapy. There's myofascial work, right? Because if we can affect people's pain, we can affect their perception of pain because we bring back movement and better functionality to the musculature and the myofascial aspects of these limbs that we don't really know where they are in space. Sometimes we get some activation of that. We better know where that limb is in space. And that myofascial work can have an effect on the brain as well. That's really powerful stuff. So then, like I said, we're going to combine the right therapies to reconnect your brain networks. Last time, I don't want to go into too much detail about this, but I talked about the maps in your brain. We need to know where we are in the world. Our brain creates these maps. If our brain isn't getting good sensory input, it's not getting good sensory input if we've got a peripheral neuropathy, meaning that the nerves in our extremities, right, in your feet, are not working appropriately, we're not going to get good feedback to the brain. We're not going to get that vasoconstriction that we need. We're not going to know where that foot is in space. Okay, our map is skewed. So we got to reprocess our maps. Right? Last time I fumbled a little bit, but I was talking about how Apple Maps was terrible at one point when it first came out and it was getting people lost. Right? And I have a bias now where I'm a Google Maps guy. I'm not an Apple Maps guy. But we need accurate maps to get to where we need to be in our world. But we need accurate maps in our brain to understand what position are we in the world. Does that make sense? Right? Are we standing? Are we not? Autonomic nervous system needs to kick it up, but not too much. But if we don't know that we're just slightly elevated, right, and our brain thinks we're in a way different position, our autonomic nervous system is going to kick in with higher sympathetic output, and then we're going to get an increased heart rate. So maps are really important. So how do we find the issues with the maps? I talked about this a little bit last time, but it's worth repeating. It's a 3-hour process typically, which is not really typical in healthcare. Sometimes it's done a little bit sooner or in a less amount of time, but it typically takes about 3 hours. So we do an in-depth history, right? We want to know who you've worked with, what's worked, what hasn't worked. We're going to take your vitals. We're going to take your heart rate and blood pressure on both sides, right? We're going to do it lying, sitting, and standing. At times, we're going to throw you on a tilt table, and we're going to see where your heart rate and your blood pressure goes awry at a different angle, right? Because you may be really cool up to like 30, 40 degrees, and then we go above that, and then that's where your heart rate spikes. So maybe we need to train you at different positions when we're talking about therapy. We're going to do eye movement testing, because different areas of the brain are associated with different eye movements. Rapid eye movements, there's many areas of the brain that are involved with that, but you could also look at it as being an aspect of the frontal lobe integrity that you have. Certain aspects of brainstem function as well. There's multiple areas involved. But there's different areas involved with left versus right eye movements versus up versus down eye movements. And those areas that are involved with those eye movements are tied to your autonomic nervous system. Okay? So is your inner ear processing, your vestibular input, where we are in gravity, that's tied to your autonomic nervous system. And depending upon feedback from that system, it was in that chart. I didn't point it out, but it was in that chart. Your vestibular system is a part of that, right? So that's why we do balance assessment, because that's going to give us input into joint and muscle feedback to your brain, to vestibular feedback to your brain, and visual feedback to your brain. And we do some cognitive testing, right? That comes from the neuropsychology realm. We don't do as in-depth as a neuropsychologist, but we do enough to get some ideas of how we can better help people. And then a lot of it is going to come from that deep, examination that we're going to do. We're going to look at your sensory processing, because that's what helps us create our maps. We're going to look at movements, because that is the result of our sensory processing, right? Movement is also, constriction of your blood vessels. That's a movement output of your brain, or a motor output. Muscle tone, the function of your cranial nerves, which are specific nerves that come from your brain and brainstem. And then observations of coordination, gait, and balance. right? All these things are indicators of how your brain is functioning because different areas of the brain have different jobs to do. Hopefully that makes sense. All right, let's talk about some real people. And these are some patients that I've treated before. One is an artist in her 30s, and she's dealing with POTS. She has some digestive issues, and she has poor physical stamina. She has poor stamina for physical and mental tasks, restricting her workload for her art and other things that she enjoys in her life. So it's really a challenge for her. But we've been looking at different aspects of what's feeding into her brain function, and we've found some things that work for her. Myofascial work works really well for her. As far as going in, looking for myofascial adhesions, and your fascia is going to give feedback to where you are in your environment to help create these maps. And she has these patterns of myofascial adhesions that come in. So we have to do the myofascial work, but then we'll do other types of neuro rehab with her, right? So that she doesn't go back into these myofascial patterns. So we're trying to address it from both different avenues. And she's doing, some of the other things that are on those lists that are important, like I talked as well. Trying to make sure that she doesn't eat too big of meals. Trying to make sure that she's well hydrated. Trying to make sure that she's eating a fair amount of salt, right, to keep her blood volume up. Another thing that I didn't mention before is, there's also the option too of some people will do like IVs, and that'll temporarily increase their blood volume. You just don't want to do it too often, because every time you do that, you're getting a needle in your arm, and there's only so often you can do that without affecting your vasculature. But it can work on a temporary basis to feel better. So for her, a big thing was those myofascial aspects, like I said, right? She's able to handle a better workload. She has a better idea of what she can tolerate, okay? Of what workload she can work with, and her workload's increased. And we're going to talk about that idea of understanding what kind of workload you can handle and the importance of that, because it can be a tricky thing. I also worked with a woman in her 40s with autoimmune issues and dysautonomia. For her, one of the big things, she'd wear compression socks, and if she didn't wear them, she'd get like severe cramping in her legs, right? And she had heart rate issues. I realized this is technically a dysautonomia case. I don't know that she'd necessarily qualify as having POTS, but it's under that same umbrella, so it's still worth bringing up. But she has some autoimmune issues and dysautonomia. So we got it to the point where we did some remapping of her legs by touching different points, by doing some electrical stim on different points in her legs to activate nerves and muscle groups, to bring a better awareness of her limbs to her body, to tilting her at different angles and doing some various therapies with her at different angles to train her brain and her body to realize, hey, I'm cool at 30 degrees. I can do this at 40 degrees. I can do this at 50 degrees, right? And gradually get to a more upright position. And she's able to live without having to wear these compression stockings now, without having pain. And that's huge. There's been other benefits as well, but that alone is a big game changer for her, right? She's living without pain, and she doesn't have to wear these compression stockings. Her fatigue's improved as well as periods of her rapid heart rate. And then I also had the opportunity as an intern to work a little bit and primarily observe Dr. Ellis working with one of the very early cases of POTS that was ever diagnosed. It was a young woman that was in her teens, and the part that I got to contribute, that made me feel good because I was a little piece of it, was we did some eye exercises, some gaze stability exercises with her at different angles, right? Once again, training her at different angles. Doing an exercise, often what we'll do is we'll do a therapy, and we'll see how it affects your autonomic nervous system, how it affects the temperature of your hands, because that's a reflection of circulation. Poor circulation, not a lot of circulation there, you're gonna have cold hands, right? Or maybe they get really hot and sweaty. That's not necessarily beneficial either. So we might check your hand temperature. We might look at your pupils and how because right? That's one of the jobs of the autonomic nervous system. So we look at those jobs that the autonomic nervous system does and see if we're affecting that as we're doing the therapy, right? So we really watched this young lady's pupils, and we really watched her heart rate. And we found that the more that we did this, her heart rate behaves better and better. So I touched on some of the therapies that we've used. There's different types of electrical stim, but one in particular is trigeminal nerve stimulation, where you can stimulate different aspects of the face to affect the trigeminal nerve. That can help remap the brain. And I mentioned how we do electrical stim, and I don't think we can catch it on camera, but like pretend this is my leg, you know, different points on the leg as well, right? Hitting different nerve and muscle groups to remap the brain's awareness of that limb in space. We could also do what's called point localization, where we touch a spot and the patient has to touch the same spot that I just touched, right? But sometimes I touch here and their eyes are closed and they're way the heck down here. They don't really know where that limb is in space. So maybe we do some electric stim, and then that point localization gets more accurate. So that means they have a better idea where that limb is in space. Or maybe we do point localization as a therapy, right? And I touch a spot, they're off. I touch a spot and I hold it. And maybe by me holding it there, they can find it. And then I go back there again and do a quick touch. And then they're more accurate getting there. Or maybe we touch while their eyes are open. And they use their vision to remap that system. And then we recheck, and they're closer to hitting that target. There's multiple different things that we can do. And I may see a patient, and based on my examination findings, it's like, yeah, you don't have great point localization in your leg, and we got to work on that. But I'll do point localization therapy, and it's not working so well for them. And for some patients, I'll do like electrical stim on their leg, and then they can find it. And then the point localization works. Other patients, that electrical stim doesn't work well for them. So then I'm going to do, maybe some myofascial work on their leg. And then their brain remaps to that. It depends on the person. I wish I had an algorithm, but one doesn't really exist. So, and then positional progressions for therapy, right? We might do therapies lying down, then seated, then standing up. Or we might tilt them on that tilt table and do therapies. And there's eye movement therapies, like I talked about with that young woman, where she laid on a table and we turned her head back and forth to the left and to the right as she looked at a target above her. That's also vestibular, but there's visual aspects of it as an eye movement therapy. So progress can be made. There's hope. I'm sorry for the heavy front end, but understand that if we look at your neurology, then we can start to figure out why your brain doesn't really understand where you are in space, and that can be a big factor in your dysautonomia or your POTS. I'm not saying we can fix every person with dysautonomia or POTS, because like I said, it's a complex disorder. But we do well, and I can give you the same guarantee that I give all my patients. It's the only guarantee I can ever give to anyone with any condition, is that we will do everything we can to help you. I wish I could give a better guarantee, but that's the one guarantee that I can give, is that I'll do anything I can to help you. So, let's talk about progress. My friend Kelly Campbell, I don't know if she realizes this, but well, she realized she posted it because she posted it. But I saw it and I thought it was awesome, and I need to tell her, and I haven't told her yet. So I'm sorry, Kelly, if you're finding out by watching this video. But I'll tell you soon. I saw she posted this online. So progress is different things to different people, right? So we're kind of looking at levels here. Let's say we want to get to full blue. We want to get to full blood volume up in the head when we stand up, because that's going to make us feel great, right? Optimal blood volume up in the head. So we want to get to full blue. Sometimes it's incremental process. It's an incremental process like we see above, okay? Sometimes it's slower going, like we see in the second line. And sometimes it's seemingly a little bit all over the place, like we see in the third line. It can be any one of those. And that can be really difficult because you don't know how well you're progressing. It can be confusing. It can cause anxiety, and it can cause depression. Because you may know someone that has a POTS diagnosis and they went to this place and they did this thing and it helped them. And then you go to that place and you do that thing and it doesn't help you. And that's got to be really rough. And it's not fair, but there's different progress for different people. We just need to know that fact. As tough as it can be, there's different progress for different people. So sometimes progress is line 3. It's not the progress we want, but that's the progress that we can work with. And we do our best to find the patterns with it. And we progress more and more from line 3 to line 2 to line 1. Every once in a while, we have elevator progress. I love those. Everyone wants elevator or light switch progress. Meaning light switch progress, you do one thing and you're functioning again. 1, 2, or 3 is more common than elevator or light switch progress. Elevator progress is, yeah, like you just get on the elevator and it just goes up, right? And you just keep climbing. But oftentimes there's bumps in the way. Number 3 is fairly common, where there's times we're doing really good and there's other times where it's tough. So we just need to know that that can be a reality, but it doesn't mean that you're not progressing. And I'm not trying to make excuses for care that you're receiving. It can make it confusing, but sometimes we need to peel back layers on processes that you're going through and how your neurology works. And sometimes it gets a little bit rough before it gets better. But progress can be different things for different people. And it's tough because on a daily basis, people talk about, how much fuel is in their tank and trying to find patterns to know what their stamina is like. And that can be part of the journey as well. And that needs to be acknowledged because it often isn't. And it's one of the things that can really mess with people when they're trying to get better and progress doesn't really make sense. And even stamina doesn't really make sense. I did this yesterday and I was fine. And I did it today and it tanked me. And why did that happen? I felt like I had a more stressful day yesterday than today. So how do we approach your care differently? I think it's worth repeating. Our in-depth knowledge of how information travels through the brain allows us to figure out your brain function challenges and the root cause of your issues. So we need to respect that neurology. It's a pretty confusing chart when you first look at it that I put up there, right? And I should have put it at the end here. But you need to have an understanding of that to be able to get to what's going on and to how we can help. So we pull the collective knowledge of contemporary research and therapy applications from several professions. And the combination of things is really what seems to make the difference for our patients, in addition to the closer look and the time that we give people. But just know, like I've said it before and I'll say it again, it takes 17 years on average for scientific discoveries to be put into day-to-day clinical practice. And that's according to the Journal of American Medical Association. So that's why we look at contemporary research. That's why staying up on the research matters. Because we want to look at the most cutting edge things and we try and apply that on a day-to-day basis in our clinic. Of course, with taking safety in mind, right? Because if you're doing things that are cutting edge, we want to keep safety in mind as well. But if drinking some more water and taking some more salt is going to help and there's not much research behind it, it's not going to fix your problem, but it's going to make you feel better, there's probably low harm in that. And I'm not saying that's one of the cutting edge things that we do here, but there isn't a whole lot of research behind it per se, but it's something that works. But we need to look at the cutting edge things, and that's what we do here. So when you combine the right therapies, we can reconnect your brain networks. You can stand up. Your heart can function more appropriately because you have a better idea of where you are in the world, and you're less dizzy, disoriented, fatigued, dealing with less GI symptoms potentially, dealing with less anxiety potentially, dealing with less heat intolerance potentially, having better circulation potentially, that whole list. And I'm sorry if I didn't mention something that's on your list, but it's a big list. But there's multiple things that can be helped by that. So if you've seen multiple practitioners for your health challenges, right, 7 or more, you deserve a closer look. So don't hesitate to reach out if you'd like a complimentary consult. We do those all the time. So this is the part where I answer questions. And I had a slide for that, and I don't know where it went, so I apologize. Does anybody have any questions right now? Now that I finally shut up. I'd like to thank the people that watched tonight. I know we've had some technical difficulties before, but I feel like we've gotten better every time we do one of these broadcasts as far as the technical difficulties. And we'll continue to do a better job, and we will continue to do these presentations, and I hope that you guys find them valuable. We're going to be posting this on YouTube for people to watch whenever, and I realize that, you know, maybe you couldn't tune in tonight, but you'll be able to tune in later and you can watch it there, and it'll be sitting on YouTube for you guys to take a look at. But I thank you all for coming and joining us tonight, so that I had some people to talk to. But I hope you guys spread some of this information. I know I word vomited to you for a long time, but I'm sure that some of this spoke to a lot of people. And if you just happen to tune in, whether it's now or later, and you weren't really familiar with POTS, you know, or you kind of suspected you had it, but you're not really sure, just know that there's hope. There's things that can be done. And know that if you don't have it, and you know someone that maybe does, or you suspect that they do, then give them a little bit of space, because they're dealing with something tough. And you may not be able to see it, but they're probably giving you their all. It's just tough for them to know on a day-to-day basis how much all they can give. So if there's no questions, I think we'll kind of sign off here, and we'll see you guys next time. Next month, we're going to have a new topic for you, and we'll be releasing that very soon. I think in the next few days. So thanks again.